Welcome back to Learning Pathology with Dr.Bhavana. In today's session, we'll discuss about nephrotic syndrome. Nephrotic syndrome is composed of massive proteinuria, edema, hyperlipidemia and lipiduria. The pathogenesis of nephrotic syndrome: basically, the glomerular capillary wall acts as a charge and size dependent barrier through which the glomerular filtration takes place. Derangement in this capillary wall results in increased permeable to proteins, leading to nephrotic syndrome. Coming to the etiology, we classify nephrotic syndrome as primary and secondary or systemic causes. The primary causes are membranous glomerulopathy, minimal change disease, focal segmental glomerulosclerosis, membranoproliferative glomerulonephritis, other proliferative glomerulonephritis like IgA nephropathy, pure mesangial and focal nephropathy. Coming to the systemic diseases or the secondary causes, diabetes mellitus, amyloidosis and SLE are the most important causes. Other causes are drugs, infections, malignant disease and other allergic reactions. Most common cause of nephrotic syndrome in adults: there is a diffuse thickening of the glomerular capillary wall with accumulation of electron-dense immunoglobulin deposits along the subepithelial side of basement membrane. Etiology: it is a complex mediated disease. 85% cases it is idiopathic. In the remainder cases, drugs, malignant tumors, SLE and infections. Coming to the pathogenesis, basically antibodies to a renal autoantigen called as M-type phospholipase A2 receptor is the main etiological agent. This protein is located at the membrane of the basal surface of the glomerular epithelial cell. Because of the antigens form immune complexes deposited at the subepithelial level as indicated by the black deposits in the diagram. This is a flow chart showing you antigen which can be exogenous or endogenous, leading to the activation of immune complex and membrane attack complex activation. Thus, there is liberation of proteases from the glomerular cells, leading to capillary wall injury and protein leakage. Already we have discussed, this is also shown in a flow chart. Coming to the microscopy, as a pathology undergraduate, you should know the light microscopic features, where you have to describe it as uniform diffuse thickening of the glomerular basement membrane. This is a comparison of the normal glomerular capillary with thin walls compared to the membranous glomerulopathy with thick capillary walls. Coming to the electron microscopy, irregular dense deposits are seen at the subepithelial level with effaced foot process. These foot processes can be demonstrated by silver stain, where the deposit is laid down as spikes. This is a line diagram showing you the light microscopy, where there is diffuse thickening. Second one, electron microscopy, subepithelial deposits and the immunofluorescence, where you have granular deposits. Next, we see about minimal change disease. This is the most common cause of nephrotic syndrome in children. Usually it occurs after respiratory tract infection or corticosteroid therapy. There is diffuse effacement of the foot process. The cause of the swollen child is nephrotic syndrome. Pathogenesis: again immunological basis. Even though there is absence of immune complexes, there is mutation in the glomerular proteins podosin and nephrin. There is primary visceral epithelial cell injury leading to podocytopathy, leading to proteinuria. Coming to the light microscopy is normal. That is the reason we call this as minimal change disease. The light microscopy is absolutely normal. Electron microscopy, there is diffuse effacement of the visceral epithelial cells or the foot process. Immunofluorescence, there is no deposit. So what do you mean by effacement? Normally the epithelial cells have foot process. When there is simplification of these epithelial cells, it is called as effacement of the foot process. Along with that, you have vacuolization, swelling and hyperplasia of the villi. There is also lipoid nephrosis, which means reabsorption of lipoproteins. So the tubules are laden with lipid and protein. So the previous name, lipoid nephrosis, is also used for minimal change disease. Coming to the microscopy, light microscopy, everything is normal. electron microscopy, there is effacement or flattening of the food process. Coming to the clinical features, we have selective massive proteinuria. So one of the cause of massive proteinuria is nephrotic minimal change disease, and the baby responds rapidly to corticosteroids. Diagnostic point is effacement associated with reversible change after corticosteroid therapy. The next one is focal segmental glomerulosclerosis. So what do you mean by focal and what do you mean by segmental? Only some of the glomeruli are affected, and in the affected glomeruli only a portion of the capillary tuft is involved. Coming to the etiology, primary accounts for only a minimum of the conditions, whereas secondary causes are the most important cause for FSGS. HIV is the most important cause, followed by renal ablation, scarring of the previous active necrotizing lesions, IgA nephropathy. Inherited forms also play a role like podocin protein, and adaptive response because of congenital renal agenesis or acquired reflex nephropathy. Differences from minimal change disease. Here there is hematuria, non-selective proteinuria, and poor response to corticosteroid therapy, and there is more likely for the progression to chronic kidney disease. Pathogenesis of the focal segmental glomerulonephritis, which I have already discussed in a flowchart. There is epithelial damage, which is the hallmark, leading to hyperpermeability. So there is escape of the plasma proteins leading to hyalinosis, and you have secondary causes like mutations of the nephrin and podocin. Coming to the morphology, the juxtaglomeruli are affected. The juxtamedullary glomeruli are first involved, followed by other glomeruli. On light microscopy, there is sclerosis leading to collapse of the capillary loops, increase in the mesangial matrix, and hyalinosis. This is a characteristic feature. There is sclerosis and only segmental involvement of the glomerulus. Coming to the electron microscopy, there is diffuse effacement of the food process, focal detachment of the epithelial cells, denudation of the underlying glomerular basement membrane. Immunofluorescence shows you IgM and C3 along with sclerotic areas and the mesangium. Discuss about the variant of FSGS called as collapsing glomerulopathy, which is the glomerulopathy associated with HIV. There is retraction or collapse of the entire capillary tuft and proliferation of the glomerular visceral epithelial cells along with hypertrophy. The tubular injury seen in the form of microcyst formation. So overall view of the FSGS, light microscopy, you have mesangial hypercellularity, there is segmental involvement and focal involvement of the glomeruli. Electron microscopy, effacement of food processes along with immune complexes with sclerosis and hyalinosis. Next, we deal about membranoproliferative glomerulonephritis, also called as MPGN. Histologically, it is characterized by alteration in the glomerular basement membrane, proliferation of glomerular cells along with leukocyte infiltration. As the name suggests, there is a deposit present in the mesangial region. 10 to 20% of the nephrotic syndrome in children and young adults occurs due to MPGN, hematuria or proteinuria of non-nephrotic range. So there is a combined picture of nephrotic and nephritic syndrome. We classify them as primary, where the causes are known or idiopathic, secondary causes where other causes are present. So you have two types, type 1 where there is activation of classical on alternate pathway, type 2 activation of only the alternate complement pathway. The pathogenesis of type 1. So antigens, which are the proteins derived from the infectious agents, are planted or trapped, leading to antigen-antibody complexes, leading to mesangiocapillary proliferation. Coming to the morphology, in light microscopy, you have lobular appearance of the glomeruli, duplication of basement membrane, leading to tram track appearance. In electron microscopy, subepithelial deposits are seen, and immunofluorescence, it is granular type. Coming to the pathogenesis of type 2, we call it as dense deposit disease, where you have activation of the alternate complement pathway. So, serum C3 level will be reduced. Morphology, you have mesangial proliferation. Electron microscopy, lamina densa has membrane ribbon-like homogeneous deposits, and immunofluorescence, it can be granular. So, this is the overall view. the glomerulus is enlarged, lobular, glomerular basement membrane is thickened, and you have a tram track or double track appearance. This is because of the splitting. The new basement membrane is produced in response to the subendothelial deposits. This diagram is showing you how a tram track is seen. At the left side, you are seeing two green areas. This is the basement membrane. So there is reduplication of the basement membrane. On the right side is the normal glomerulus. So you can see the double glomerular basement membrane, which is called as the tram track appearance. So this is the immunofluorescence showing you intense staining of the complement in the type 2. This is the tram track which I was speaking about. So overall view, under the MPGN, the deposit is subendothelial, immunofluorescence, type 1 and type 2. This is a diagrammatic representation of type 1 and type 2. Type 1 tram track, type 2 dense deposit disease. Lastly, we discuss few systemic diseases associated with glomerulonephritis. Here I am showing you the most important cause of nephropathy, diabetic nephropathy, where there is sclerosis and the kidney is enlarged. Next one, associated with Goodpasture syndrome, where you have microscopic polyangiitis and there is focal and segmental glomerular sclerosis, extensive necrosis, fibrin deposition is seen, and also crescents are seen. Next systemic disease is SLE, which is called as lupus nephritis, where we have 6 types of glomerulonephritis. Type 1 minimal mesangial lupus nephritis, mesangial proliferative. Next condition, Henoch's choline purpura, where you have purpuric skin lesions, abdominal pain and intestinal bleeding. There is diffuse mesangial proliferation and endocapillary proliferation. IgA, it is deposited. Thank you.